hello to everyone tuning in to Medical Festival Asia this week. And to today's session, are we living in a time of greatest threat or opportunity for healthcare innovation? We have an absolutely insightful session coming up to start our digital innovation and medtech track. This session is actually brought to you by Proton Global Ventures, which is an impact-driven medtech-focused VC in Singapore. They look for companies globally that can inject value into the patient care system, save lives, and reduce the supply-demand gap. Essentially, they're really looking for innovative firms and ones that save life through medical access, medical development, and innovations, which in their hope is to save 100 million lives in 5 years. With that, and specifically looking at innovation, let me introduce today our panelists, Professor Basky, the Clinical Director at Tommy's National Center for Maternity Improvement, Professor Thomas, Chairman of the Board at Leo Cancer, Vice Chair, Board of Directors, International Commission on Radiation Units and Measurements, Professor Philip, Associate Dean at Faculty of Medicine, the Chinese University of Hong Kong. Thank you to all our panelists for joining today, and of course, coordinating between 3 different time zones to accommodate this session. I'm really excited for our conversation today. The 3 of you have an absolute wealth of experience across specialties and markets being based out of the UK, US, and Hong Kong. And of course, within innovation, where beyond the many medical accolades within your field of specialty and multiple publications, all of you are also active with advisory and participation at multiple firms, from startups to large corporates, and of course, advising national health systems and regulation participation. That diverse views today will really help our audience understand innovation from multiple perspectives of both collaborating parties, entrepreneurs, and the driving forces for the industry at large. As such, before we delve into this kind of discussion, I think it would be only best that we split today's session into two parts. The first one will be focused on each one of you just sharing a bit of your backgrounds and the work you've done with different companies so that the audience understands where these perspectives are coming from. And then from there, we'll move on to a panel discussion to really look at the state and the trajectory of innovation. On that note, Professor Thomas, could I ask you to go first, followed by Professor Basky, Professor Philip. Thank you, and let me now hand it over to Professor Thomas.
Thank you. My name is Mackie, and I'm an emeritus professor and entrepreneur. I was a professor at the University of Wisconsin in medical physics for about 25 years. I founded 6 companies, and during this introduction, I'm going to talk about Leo Cancer Care. So the first company was started in 1992, and it really pioneered radiation therapy treatment planning. It was actually software paid for by the university hospital, and we developed it at the university and implemented it first at the university. In 1992, we started a company so that we could take it for FDA approval. And we found a company to market the software called ADAC. And we were actually paid for this FDA approval phase of the software in advance against royalties, which is, I guess, a typical academic like book deal. In 1996, after FDA approval, we sold it for about $7.4 million. And at that time, it was likely worth about $40 million because it went on to sell hundreds of millions of dollars worth of the software and really dominated radiation treatment planning for about 20 years. And really the upshot of that company is that we really should have hired a business manager when we started the company. As academics, we were a relatively early academic startup, and there was really no one at the university to help us at the time. We really learned from that because in parallel with the working on geometrics, we had started a project at the university called tomotherapy. In fact, it was funded by General Electric for 3 years. And in 1997, they got out of radiation therapy and kind of left us high and dry. But we then had some money from the geometrics company to start tomotherapy, and it was funded in 1999 by 2 venture capital groups in the Midwest of the US. We did very well. We had up to $240 million of revenue in 2007 and went public. However, we were not profitable in service. So the more we sold, fundamentally, it didn't add to profitability. It subtracted from profitability. And we sold to another radiotherapy company, AMBulatory, so that we could scale, so that that combined company could then scale the service. And I think the major thing I learned from this company is that you have to be continuously open for a merger or acquisition as a company grows. And in fact, AMBulatory went public just before we did, and we really should have merged before we went public. It would have saved a lot of headache. So I really want to talk about my latest company, Leo Cancer Care. And Leo Cancer Care is pioneering upright radiotherapy. And really, we should be treating most of our patients in the upright posture. And the reason for that is the lung has less movement because the lung is more inflated in the upright position. There's no systematic liver drift, and there's less issue with bladder filling. In prostate radiation therapy, men are asked to fill their bladder, and it's very uncomfortable than getting a radiation therapy treatment with a full bladder, sometimes taking as long as 20 or 30 minutes. And there's other reasons, good medical reasons for upright radiation therapy. And what we really want to do is create a revolution in proton beam radiation therapy first by actually putting a CT scanner in a vertical position so that it can scan the patient either completely vertically or at some angle about vertical, and then have the proton beam be stationary rather than a gantry for the proton radiation therapy. And then so the idea then is to rotate the patient instead of rotate a giant gantry. And so the combination really of being able to have an upright radiation therapy with better medicine and a far less costly machine is really the key to Leo Cancer Care. And so traditionally in proton radiation therapy, they've used big gantries. And what we want to do is change it so that at least some of the gantries are upright in nature. And you can see they're far less expensive, savings of up to $14 million by having one gantry and one upright system. And so really what we want to do is expand the capabilities of proton radiation therapy and reduce costs at the same time. We think that the upright radiation therapy will actually become the workhorse machine because it's, again, more medically beneficial for many types of cancer. And historically, we've really only treated head and neck cancer upright. And so this system is going to expand it to lung, liver, and prostate. And there's a lot of patients who really cannot lie down. As I mentioned, people are often uncomfortable lying down, and they should have the advantage of getting radiation therapy as well. Whereas the gantries can be really a specialty machine for a few of the patients, for children, for relatively rare sarcomas in the leg. And there's a few adults who cannot sit down for various reasons. And then there's a few adults that need general anesthesia. And at least practitioners today are often more comfortable with patients lying down. But we, in fact, think that general anesthesia in the upright is practiced, and folks in radiation therapy will become comfortable with that. So thank you for that introduction. I look forward to the panel.
Thank you, Professor Thomas. So that was obviously very insightful, and exactly what I was referring to, that our panelists today have a wealth of experience across multiple companies. To continue building on that, Professor Basky, could I pass the floor to you now to just introduce a bit about yourself and maybe the work that you're doing that lends to this innovation session?
Thank you very much. I'm Professor and Director of Fetal Medicine at St. George's Hospital in London, and also the Clinical Director for the Tommy's National Centre for Maternity Improvement in the UK, which is based at the Royal Colleges of Obstetrics and Gynecology, as well as the Royal College of Midwives. And therefore, my role is principally about pregnancy care and specifically the unborn child. I have a very short and perhaps not as technical presentation as Rock has, and a much more simple problem that we're trying to solve. And the major problem here is placental dysfunction. As you know, the placenta is a multi-organ substitute. So whereas we have lungs and hearts and bowels and kidneys, the placenta does everything for the baby. So the placenta is responsible for both nutrition, oxygenation, respiration, as well as excretion. And if the placenta doesn't work, then there are multiple consequences, both to the fetus and to the mother. For example, a lack of nutrition can lead to growth restriction, so a small baby. Lack of oxygenation can lead to hypoxia and death or stillbirth. And a maternal response to inadequate placental function is to try and force more blood through the placenta, ergo a condition called preeclampsia, which is high blood pressure in pregnancy, which is a maternal response to poor placental function. Just to get an idea of these conditions in the UK, for example, there are approximately 2,000 stillbirths every year, and preeclampsia kills about 40,000 women each year throughout the world. If we, you might be tempted to say, well, 2,000 isn't that much, and 40,000 in the scope of things compared to, for example, COVID-19 is a very small number. But if you want a real global perspective on the rates of placental dysfunction, this is a map showing how growth-restricted diagnoses are made in neonates. So at the time of birth, looking at what the prevalence of malnutrition is in a neonate. And you can see here the representation of poor fetal growth diagnosed at the time of birth. And you can see that the coverage, and it is no surprise to you that developing countries and lower middle-income countries have the highest rates of neonatal growth restriction and neonatal malnutrition, but it is by no means a missing problem in the developed world. So this gives you an idea of the scope of how much placental dysfunction is a key issue in pregnancy. So the presumed solution really for the last 20 years has been the fact that ultrasound is going to revolutionize the care of pregnancy. And indeed, with ultrasound, it's possible to look through the maternal abdomen and to measure fetal size and look at how well the baby is and how big the baby is, I suppose. The problem we have with using ultrasound is that ultrasound is specific to looking at the size of the baby, so telling you whether the baby is large or small. And if you look at the panelists here are of various sizes, shapes, colors, and heights. And yet that tells us nothing about their health or their oxygenation. What we are failing to understand when we measure fetal size is that the relationship between fetal size and fetal oxygenation, which results in disability and death, that relationship is very, very poor indeed. And in fact, 80% of the stillborn babies at term, which is 9 months, are not small. So a policy or program of using expensive technology like ultrasound to check the baby's size will persistently miss 80% of stillbirths because they will not correctly identify the babies that are normal in size, but yet suffering from hypoxemia. So how should we monitor these pregnancies? And there is a conventional technology which is being used intrapartum, which is to listen to fetal heart rate variability. And I do mean listen. It's a sound-based technology called cardiotocography. And this sound-based technology is able to look at heart rate and heart rate variability. And by looking at heart rate and heart rate variability, we get insights into the current status of the fetus, so how the baby is now. And this technology has been applied antenatally for many, many years now as a method of assessing fetal well-being when either we're concerned about a high-risk pregnancy or the mother presents, for example, worried that the baby is not moving as it normally does in advanced stages of pregnancy. However, what is extremely disappointing is that this was a large study that we participated and conducted, was published 2 years ago now, called the AFFIRM study in the UK. This was a review of over 400,000 pregnancies, a step wedge cluster randomized trial, where women who presented in high risk or with reduced fetal movements were given an e-learning package, some information leaflets, and then had a program of investigations which included CTG, which is cardiotocography, as well as ultrasound. The reason it was disappointing is that the stillbirth rates in the arms that had conventional treatment versus the arms that had heightened investigations using CTG and ultrasound had no difference in stillbirth. You can see in that red block that the adjusted odds ratio was 0.9, and that crossed 1, and therefore there was no significant difference in stillbirth before and after the introduction of this program. What was really important to understand is that when ultrasound was done, there were increased rates of iatrogenic preterm birth because the physician thought the fetus was at risk and delivered these babies unnecessarily early. And that resulted in increases in birth, operative birth, and also resulted in increased neonatal admissions without any change in the stillbirth rate. So we increased unnecessary operative intervention, morbidity to both the mother and the baby without really changing the rate of stillbirth. Now, you already understand why ultrasound may not help in this pattern, because ultrasound is purely a size-based assessment, which doesn't tell us about whether the fetus is hypoxemic. But the heart rate, we know, varies when the baby's hypoxemic. So why did the use of CTG not change? And it's because of this. First, the CTG is a hospital-based device. And therefore, that is a geographical limitation. It is only based there, and the woman has to turn up to the hospital to have the assessment. By necessity, a hospital cannot have 100 CTG machines, so we may only have 3, 4, or 5, which means there is a capacity issue that you can only, yes, have 1 midwife per woman per CTG, which you may only be able to do 2 or 3 CTGs at any given time. Secondly, the cardiotocography device, the sound sensitive device, has to be applied by a trained expert, by a midwife or a nurse or a doctor. And therefore, you have to take the midwife away from whatever she's doing, and she has to apply this device with the appropriate expertise and remove the device. Ergo, the woman is stuck in the hospital. She can't put the device on and walk away. She needs a midwife to apply it. She needs a midwife to take it off, and she can't move from the area. And finally, most of these heart rate patterns, the sort of squiggly lines you saw earlier on, are doctor-based interpretations. And inevitably, doctors are less frequently found in hospitals than midwives. And secondly, there is huge variability between one doctor and another about the interpretation of the squiggliness of the line. So I could show a CTG to a colleague who would say, well, that looks fine. And I may look at it and say, well, actually, I'm suspicious about fetal well-being because the variability of the heart's not very good. And there's only so much one can do with manual interpretation, very much like Rock showed about the wealth of information that's produced by imaging techniques, be they ultrasound or CT. There's only so much an individual can do, and there will be disagreements within individuals. So what's the solution? The solution is a device that Biorhythm have come up with, which is an ambulatory fetal ECG device called FEMON. This is what it looks like in application. And very simply, it's a non-invasive abdominal ECG device. So it measures electrical signals, not sound signals. And by subtracting maternal signals from the background, it's able to measure fetal heart rate and fetal heart rate variability. And this is connected via Bluetooth to a mobile electronic device, either the woman's phone or her iPad, and therefore sent to the cloud and accessible by the healthcare practitioners remotely. And additionally, it uses an AI-based algorithm to assess the squiggliness of the line. What this means is that we have a high-capacity device. You can buy 20, 30, 40 of these devices. They're ambulatory. The woman can put it on and disappear, go home. And in an age of COVID, in an age where most of my research programs were stopped on the 23rd of March in UK, this was one of the research programs which was prioritized as being extremely important because it allowed women to have the level of care that they would need from a remote location and not being exposed to the hospital environment. It's a non-specialist application. The woman has to put it on her abdomen. There is no special place it needs to put on because the ECG signal can be read through the abdominal skin. There is consistent interpretation because we're using an AI-based algorithm which will reproducibly and repeatably assess the heart rate and the heart rate variability. We can have consistency in interpretation and accuracy. And finally, there is significant digital interoperability, such as this device is built to work with other major patient or maternity information systems and therefore can integrate with whatever systems you're using. What is my role in this? I'm not a paid employee of Biorhythm. I'm a research collaborator, so my institution is funded. I have no pecuniary interests here, so I just get my standard salary from my government hospital pay. But Biorhythm have entered into a collaborative agreement with my institution to do the AMBER study, and that's ambulatory fetal ECG in high-risk pregnancies, to establish the reliability of FEMOM as an ambulatory fetal monitoring device in the assessment of fetal being, compared to conventional methods, which is CTG and ultrasound. And there are two parts to the study. The first part is to compare the fetal heart STV. STV stands for short-term variability. That's the squiggliness of the line that doctors are asked to interpret with their eye, measured by electrical FEMOM signals versus the auditory signals that we conventionally get from a conventional CTG device. And the second is the assessing the sensitivity of FEMOM in the detection of fetal hypoxemia in early onset growth restriction. A few years ago, we led in the world's largest study of early onset fetal growth restriction, where we assessed 600 babies in a study called the Truffle Study, which now has set the state of the art in how you monitor early onset fetal growth restriction. And therefore, we have a high volume of these very rare cases coming to the unit that allows us to use this device in really high-risk pregnancies, whereas in most units, they will only have access to normal pregnancies. I'd like to thank you for your attention.
Thank you, Professor Basky. You know, health gives everyone a peace of mind, and the only thing that is more important than one's own health is usually the health of their to-be newborn. So that's pretty incredible. I'm sure with that depth of innovation, it's not just in terms of the medical side, but also it'll be good to hear in the panel just how that company went about doing the collaboration with your firm, how the trials are done. But we'll come back to that. Before we get into that, could I pass the floor to Professor Philip just to share a bit about your background and maybe the work that you have done recently too?
Thank you very much for the invitation. My specialty is I'm a surgeon, but I also perform flexible endoscopy. So I think for the development of endoscopy over the past 60 years, this has been enhanced by the use of light source, optics, and also processor. And 50 years ago, it is by the camera. And now we have the CCD and the CMOS. But on the therapeutic side, it's only with the addition of the working channel. So which part of endoscopy may be improved by the current technology? I think image processing and analysis can be improved through AI technology, while steering and locomotion of the endoscope can be improved by image guidance and also robotics, and treatment definitely will be improved through robotics. So how AI can assist in standardizing the process of diagnostic endoscopy? So we can actually locate the GI tract through anatomical localization, image capturing, detection and characterization of any pathology using AI. So in that perspective, I have privilege to collaborate with a Hong Kong startup company, the EndoVision, and developing the AI-driven examination protocol as standardized positioning, so that to ensure the endoscopists will be able to examine all parts of the upper GI tract, and so that also the exam time will be assessed and standardized with the photo image capturing. So this is one of the video to demonstrate the current system of this cerebral. So through the endoscopic examination, we'll be covering the upper GI tract. So there would be a automated photo capturing system. So, and again, pathology actually will be photo taking. And I think through this technology, by the use of this cerebral, we have 100 patients that receive the current validation study and demonstrating an accuracy of 95%, sensitivity and specificity of over 90% for localizing the anatomical position in the upper GI tract. So with the AI-assisted endoscopy, I think there would be improvement in the efficacy and quality of the diagnostic endoscopy. So we'll be able to detect more pathology at the early stage. So that would increase the potential of therapeutic endoscopy in the future. And currently, the early upper GI cancers are actually treated by a technique called endoscopic submucosal dissection, or ESD. Instead of performing a surgery to resect the organ, we'll be able to preserve the organ if we make the diagnosis of this tumor at the early stage. And through AI technology, we'll be able to detect more of these lesions at the early stage. And with the preservation of the organ, we have a better quality of life for the patient and also better post-operative outcome. But if you look into this video, you will find that the endoscopic device or the surgical knife is actually moving together with the endoscope. So that makes the technology very difficult to practice. So this is a photo like what we are doing for ESD by the surgeon who are attaching this knife to this forehead and move around for the dissection. So that makes the procedure very difficult. While at the present moment, for minimal invasive surgery that I'm practicing, we are applying robotic technology with a stable platform that allow us to have a precise dissection of lymph node. For example, this is a radical gastrectomy that I did. And with the robotic arm, we'll be able to dissect lymph node over the splenic artery here without damaging the artery at a highly accurate and precise manner. So with this in mind, we actually developed the master and slave transluminal endoscopic robot. And the pioneer is Professor Lawrence Ho from National University Singapore and Professor Lawrence Louis Free from Nanyang Technological University. So I am actually a clinical advisor to this system. And by attaching the two robotic arms to the flexible endoscope, we complete our first in-human trial in the year 2011 with 5 patients with early gastric cancer. So this is a concept that we use a robotic arm through the flexible endoscope to lift up the mucosa and perform the submucosal dissection. So the system has been refined and currently available as a second generation and developed through this startup company, the EndoMaster, based from Singapore. And it has an independently designed flexible robotic platform with a built-in imaging system and also working channels for the robotic arm. So because of the COVID, I think we have actually advantage of starting the clinical trial in Hong Kong because we have a much less other activity being engaged. So actually we start this clinical trial in May this year for performance of colorectal endoscopic submucosal dissection through the system. So you can see this two robotic arm. It's being introduced through the flexible endoscope. This video has been played 5 times in speed. The videos last for 4 minutes. So the procedure time is around just 20-something minutes. So in the colorectal ESD, it commonly lasts for like 90 minutes. So this is actually a much faster procedure. And you can see that we can lift up the mucosa and resect the tumor at the high precise manner, dissecting at the submucosa. And you can see here we can lift up the mucosa. And at the same time, we can also use the robotic arm to compress on the colonic fold. So that is another advantage of the system that allow us to have a lifting action and also have a compression action. So very much like a surgical dissection with a surgical robotic arm using for the retraction and exposure. So now at the submucosa, we are completing the dissection here. So this is the final part of the dissection, and we can actually take the specimen out through the robotic arm. So, and this is the system of the concept. I think one of the area that we can do is to redevelop the whole endoscope and the robotic arm. while the other manner that we can take is in fact to build the robotic arm on existing platform. So in the Chinese University of Hong Kong, we are also developing a flexible robotic arm for manipulation and for treatment. So this is our system, which also have the 2 robotic arm for dissection and for the lifting. So I think with this back in mind, back in Hong Kong in the year 2018, the Hong Kong government actually set aside 10 billion Hong Kong dollar to establish 2 research clusters in AI, robotics, and health. And we are very honored to establish this multi-scale medical robotic center under this Hong Kong government grant. And we have 5 years to establish a medical robotics center and to enrich the R&D in medical robotics for clinical application and also to enhance international collaboration. So currently we are collaborating with Imperial College London, Zurich ETH, and also Johns Hopkins University. And we hope to build a platform for industrial collaboration, the capacity for talents in the field of medical robotics, and nurturing the startup community in Hong Kong as well. So this is our dream of an ecosystem for R&D in medical robotics. So our university is situated here in this side of Hong Kong in the Sha Tin. And we have a research facility over here. We also have the Hong Kong Science Park, which is very near to our university. And we set up the medical robotics center there. And I'm working in this Prince of Wales Hospital. And also we have a new Chinese University Medical Center being established. So all this travel will be just within 15 minutes of drive. So that enhance the cycle of development from basic research all the way to clinical application. And this is our research lab that we wish to build. And we would have hopefully an image guided combined with robotics in a single research lab that we can perform and improve on the technology before clinical trial. So hopefully in the future, we can develop the medical robotics and become one of the leaders in the Greater Bay Area in China. So thank you very much.
Thank you, Professor Philip. So that's actually a great segue to the panel, because your session touched upon invasive surgeries. We had some external medical devices in earlier non-invasive versions, and obviously with cancer care, large hospital systems and equipment. So there's really a full spectrum, but also your session leads well into the conversations on both government funding, funding for companies, and maybe what we can do before really stepping into the topics which I think are underlying between all of you around AI and data is maybe we begin with that initial conversation on really the fundamental question of this panel, which is, are we living in the greatest threat or opportunity for innovation in healthcare? And maybe with this year, I think the first question maybe I'll open up to the floor is the turbulent financial landscape that I think a lot of companies have experienced. Have you had any insights in terms of, people always assume healthcare is not neglected, but healthcare is very vast, and as we've seen just between the 3 presentations, quite diverse. Do you see an impact on either your research, funding for research, and or maybe the companies that you're working with? Have they seen a difficulty in investing into themselves, or has it been a good year? So maybe if I can ask, Professor Basky, would you like to just open that up, and then we can have all of you, of course, feel free to chime in as you please.
Sure. Thank you, Baron. I think your question was specific about opportunities in research funding. Absolutely. Being at the technical end of obstetric research, I suppose, a lot of our projects are prioritized because they have real world value, not only in improving outcomes, but actually they engage with digital technology. So my major role in the National Center is to produce a very mobile digital application which helps integrate healthcare data in a large scale. In terms of access to funding, it's a real issue. Absolutely, it's a real issue. So most of the charities and funding organizations have had a real downturn in their income this year, and therefore almost certainly there is less money available. Secondly, next to the mighty academics like Philip and Rock, you've got to understand that pregnancy care is less than 5% of the workforce. So when I go cap in hand for funding from a charity or a healthcare funder, 95% of the competition is someone who turns up saying, I'm saving lives from cancer, or you know, I'm dealing with therapy or diagnosis, and it's a real hard ask. And that's wrong in my view, because quite frankly, there are 150 ways for any one of us to die. But there's only one way for us to be born. And evolution has a disproportionate effect on the birth process, which will have lifelong consequences. Which is why, Varun, your festival and your Congress is extremely important to us. So biorhythm was a consequence and accelerated by COVID, because they saw the need, they saw the value, and they said, we need to do this. And I think we are increasingly going to rely on commercial collaboration.
Actually, so it's going to just maybe a quick follow-up to that is, you mentioned that during COVID, a lot of research was held back to prioritize funding or data towards the vaccine development. And yet yours was one of the first researchers that was bought back. And yet you've got this dilemma of, I guess, investment difficulties. But in that environment, at least where there is support to bring back research and data, how are you seeing the individual companies that you're working with or that approach you? Is there still enthusiasm or hope that, look, we're on the right track, and despite the difficulties that there may be, the founders are encouraged to keep, and is the innovation still moving forward?
Yes, there are. I mean, so the story in the UK, and it may well be different in the US and in Hong Kong, the story in the UK was all research was stopped on the 23rd of March, and only COVID-related research was allowed to continue. So it was completely stopped. We had to then reapply for research which had value in the COVID era, which is why a couple of my projects were restarted, because they had value in the research era. So they then prioritized return to research for specific projects in a very small proportion, about 10% of the projects. In terms of our collaborations, the collaborations that relied on technology and ambulatory and had a value in COVID accelerated. And I had relationships with other companies that were not engaging in so-called ambulatory technology, etc. And they are basically treading water. And they're still very keen. My view may be very biased because I have a very niche specialty, and therefore it's in their vested interest to maintain a relationship with me. I cannot say, Varun, that perhaps the potential relationships they may have developed pre-COVID have occurred in this era. So I can only speak for myself. They're just treading water, knowing that I can't do any work with them at the moment, hoping that post-vaccination we'll get back online.
Professor Thomas, on your end, I mean, we really see some of what you're developing, yes, needs a lot of investment, but also on the back end, or once implemented, could be tremendous savings, but also advancements for the level of care. I mean, in the US, how are you seeing the market evolve in terms of either entrepreneurs encouraged, people like yourself encouraged in the work you're doing, and also possible difficulties that may have happened during the year?
Well, I mean, I think it's interesting that, you know, cancer didn't take a holiday during the COVID crisis, and heart attacks didn't take a holiday. So, you know, critical care like that has to get done. And I know in radiology and radiation oncology related to cancer and cardiology, nothing really changed. In fact, it was probably, if you like, one of the busier years, as a matter of fact, for cancer care in the United States. In terms of investment, I think at the beginning there was quite a bit of money flowing into the COVID area, but I think people realized that this is probably not a long-term investment opportunity. And so I don't think it really changed, or at least for good technologies. I know Leo Cancer Care was able to raise money. OnLoom was able to raise money because they're good technologies that will both save a lot of money and advance care. In terms of, and so if you had money and you could raise money, then it wasn't a bad year. It was a great year for development in many ways because you had an opportunity, especially a small company, to make advancements when the big companies were struggling to sell their existing products. because it was a terrible year for selling stuff to hospitals in areas that COVID. I mean, you literally could not get your representatives into the hospitals. They were banned. And so it was a very difficult year for existing companies. So kind of a good year for startups.
And the entrepreneurs behind, I guess, the companies you're working with, have you seen their level of enthusiasm or their ability to push forward? How has that been behind the scenes?
Yeah, no, I think in terms of virtuality, I think the companies in a development stage now with modern technology you can work from home. You can take licenses for SolidWorks and do mechanical design at work. Simulation software is available so that you can do science simulation from your bedroom if you want. So in terms of well-designed R&D startup companies, I mean, Leo Cancer Care is distributed only 17 people over 2 continents. And I think we've done an excellent job of finding the best people. When we hire people, we don't ask them to move. Right. So it actually gives us a planet of the best possible workers, because we don't have to force them to come to one place. So I think that's going to change the way that especially startup companies are done. And big monolithic central areas where you would do R&D and development. I mean, you have to get together and build things in one location. But in terms of the most functions now can be well distributed.
So actually, if I can maybe ask Professor Phil, because that leads really well onto the Hong Kong market. And in the end, you mentioned the government fund and the scheme that has been established for robotics. How is, I guess, funding aside, but because I would assume that's quite well given the programs that are there, how has innovation moved forward, or how is that project done this year? Has it brought a level of enthusiasm, or at least can sustain that enthusiasm amongst the community? And maybe building on that in terms of the community there and what's being pushed forward, is it with a focus for Hong Kong? Is it with a focus for exporting that technology out and across the region? And is it considered region in terms of APAC and global, or primarily maybe your neighbor, China? So if you could just share the insights into how the dynamics in this region are working for that center and the government fund there.
Thank you, Roland. So in fact, I think same to as mentioned by Professor Thomas. So the healthcare innovation has not stopped. Actually, it's been booming. In fact, in Hong Kong, I think there's a lot of opportunity of investment, and we can also see more and more startup company being established in the medtech area in Hong Kong. And for the government, our government is also pushing a lot in the technology development. As I mentioned, the government set aside funding and already approved and already running for 2 research clusters, one in the health, the other in AI and robotics. So there has been a lot of R&D activity being happening here. And on the other side, I also see that the COVID situation somehow enhanced our adoption of technology to push forward this kind of development. For example, my clinical trial on the robotic system developed from Singapore Endomaster system, they are not able to travel to Hong Kong, so they cannot provide any technological support. So what we did is, in fact, a tele-monitoring and telecommunication that usually people do not rely on so much because they have no confidence, but you have to do so, and then actually those are running very well. So with such some minor technological need and support, then we actually completed the clinical trial cases, and also this allow the frontline, as I mentioned by Professor Basky. So in fact, our initial clinical activity was also damped down. So there's a lot of R&D clinical research being stopped or withheld at the very beginning of the COVID. But because of the multiple waves that we have experienced, now we know which kind of research activities should actually be maintained. And also, I think that, as mentioned by Rob, the cancer will not stop itself. So we are trying to, if we defer too much of the diagnostic procedure like endoscopy, we have a pile of patients being waiting for a long list. So right now we are actually trying not to stop our clinical activity and provide this diagnosis. So the more the endoscopy that we did, the more cancer that we detect, and then the patient come into the clinical trial, and they actually accept to be participating in the clinical trial as well. So
I mean,
it's
yeah. For everyone, the market is doing really well. And you were talking about these new shifts, working with Singapore. Maybe I can open up to the floor, anyone that would like to answer this. Are you seeing a shift in how innovation is occurring? Any shift in business models or processes? Because it sounds like the core offering is still moving around. But if someone is entering the healthcare space or looking at it and looking at the innovation, whether from an entrepreneur, obviously there's hospitals that have their own innovation departments. If you were responsible for innovation, is there something that you should know in terms of the change that's happening across business models or possibly processes to keep progress happening?
I mean, there's going to be a revolution soon in AI for sure. And that is, I think, going to be first seen in electronic medical record mining, genomics, and radiomics. Radiomics being basically image processing. And, you know, what I think is going to be the hallmark of future future healthcare is following a patient from a patient-centric point of view. We put patient records now into silos based upon episodes and disease types and the specialties that they see. We really do need to take from birth to death far more patient-centric point of view. Probably will involve patients having their own medical records for life that they then are responsible for as a backup. But we really do need to have the transportability of healthcare records so that we can properly mine and do research based on retrospective data and be able to then design proper prospective trials to see which technologies and processes work the best for a given patient.
I guess maybe two questions around that for everyone. I think one is, I think the patient-centric model is something that healthcare has focused on for maybe the last 10 or 15 years as a concept. And to a certain extent, the patient journey, the patient experience has been looked at. But there are stakeholder issues in terms of, or at least the centralized patient having their healthcare records is being an ideal, and it still hasn't happened. Do you see that happening sooner than later? And maybe along with that, do you think that is a core development that could or should lead to the next leg up of innovations? And if so, in which manner? And I ask this from the perspective that obviously the three of you are running very different elements of healthcare, and would having greater access to a database of records really assist, or would it only assist in certain areas? So I guess
I mean, I think the fundamental problem today is that healthcare records, electronic versions, are just imitations of paper records. And in fact, most facilities, that's what they want. They want to be able to get rid of their paper charts, but they want to have the same information presentation. And it doesn't really make sense, because if you hold a chart in your hand, you can feel with your thumb, you can find information quickly. But if you make that electronic, then you essentially are hunting for the data. And we need AI really to help sort it out. And so it'll come in phases. So I remember in radiology originally was the radiologist, when you went electronic, was just a replacement of putting the films up on a view box. And so the electronic presentation of that was just an imitation of that. But quickly it was found that you didn't want that. You wanted the ability to be able to scan quickly through the patient in 3D and be able to see and understand the patient in a new way. And so we haven't achieved that in the rest of the electronic medical record yet.
Professor Basky?
It's happening right now in the UK. So the Tommy's National Centre, which I lead, has developed a medical device which does exactly all of those things that you asked for, which is allows the patient to carry their own records, and it's demonstrated in a way that is patient or woman friendly and patient centered. It embeds AI algorithms in it, already developed AI algorithms, which help with both risk assessment and clinical decision support. And it's built future-proof for data interoperability so that it can link to, for example, our neonatal child health and adult databases. So we will, within the next few years, have potentially the most comprehensive, intelligent digital records, not just digital paper, as Rob quite rightly put out, which is what the current systems have. So we will have records which produce context-specific information. So you don't have to go digitally thumbing through pages to find out the right information. All you have to say is the patient has presented with blood in the stool, and then bang, all the correct information that you require shows up. Yes, we have more processing power when you're ordering an Uber or buying a pizza, and yet, you know, Rock and Philip quite rightly say, you know, we got paper notes and we got digital paper and no real intelligence in there.
So
it's coming up now.
The next leg up, with this push on AI, do you think the next level of innovations, or really the next disruption, will it be the next med tech development, the next physical device? Will existing devices be able to leverage the AI data more? Or do you think the next introduction of healthcare innovations will be solely digital and service driven? And how would one even begin that journey? Because there's such a vast layer of data. Are there certain elements of that data that people are already starting to look at as a primary look? The first thing we do is here.
Yeah, I think so. For the previous question and this question, in fact, the one of the example is the startup company that I'm working in Hong Kong with the EndoVision. In fact, I think electronic data is one of the area, and the examination, imaging, analysis, and the whole process of the examination could actually be standardized by the AI-driven protocol. We have always seeing the difficulty of mentoring all our junior endoscopists, and the standard and quality of the endoscopy actually varies between different persons. So with the AI coming in with the standardized-driven protocol, we can allow the endoscopists to have a more standardized way of reporting the examination, capturing the location of the photo, the pathology, and as well to avoid missing of any area that the human can actually have an error. So I think that is an enhancing technology, and I would believe that the AI will be applying in a lot of area just within the next few years.
Yeah, and Professor Basky, I think you were, I mean, are there other examples on where you would see the innovation coming through there as well in AI, and maybe which direction?
It's principally low-hanging fruit, Baron. I think that AI and digital technology is going to revolutionize healthcare in the next few years, potentially because old people like myself, Rock and Philip, will die out, and the younger generation who are much more receptive to a black box technology, because generally people of our age are much more resistant to listening to what a black box tells us. So the new generation of doctors are more receptive to it. So there is an open market. There is a need for it. We are 20 years behind every other industrial activity. Health is way, way behind. Companies can come and have low-hanging fruit. What is missing, Marion, is like a dating agency. You've got companies out there who've got money to spend, who've got technology that they want to do. Then where in the world do they go? How do they find the right people? How do they find, and events like this are where you should focus on saying, who are the right people to take this technology forward and translate it into clinical practice?
Yeah, and by the way, I recoil at the word black box, because I think humans are, if they're still going to be in charge, need a story. So I think AI is going to fail unless you can have the AI report to a human in a reasonable amount of time, in something that a human can understand about the decisions that the AI program is suggesting. And that's absolutely human nature. And just imagine what it would be in a litigation in court, and you have a jury that's listening to a physician and listening to an AI data stream. They're going to listen to the physician. And so you know, while I think AI is very powerful, it's not powerful unless it can tell a human story.
I couldn't disagree more, to be honest. I couldn't disagree more. So the reality is, you know, the definition of madness is we do the same thing over and over again and we expect a new result. And that's simply not going to happen with physicians in place. It introduces natural variability, different skill levels, different skill mix. AI is there not as a replacement. AI is there to use the digital information that's there and produce context-specific guidance. You're still going to need a physician to act on it. But if you let the physician distrust the AI because it's a, you know, it's hidden technology, then that's going to be a failing. And that's typical of people of our age because we have that mistrust to say you shouldn't do it. Now, the AI we use has been developed in hundreds of thousands of pregnancies, has been externally validated and shown to be 4 times better than a physician. But we don't take the physician out. We just integrate our AI algorithms into their care pathway and then share the information with both the mother and the physician and produce it as recommendations, not instruction. So it's just we have a cultural journey and a behavioral journey to undertake where we have to accept the value of this technology and learn how it needs to embed in our healthcare systems. It is not an issue of trust and mistrust. It's an issue of cultural change.
Maybe I usually take the example like in the past I actually study the map and before I drive, but then now we just use the Google Map. We are not relying on the Google Map to drive, but it's a road map for us just to follow. But we have all the autonomy of how we steer our car to whatever place. But with that guidance, it actually gives us the confidence. So like endoscopy or surgery, I think we need those guidance for the next generation surgeons.
So maybe the next generation surgeons, I'll use the example that you used on a Google Map. There are many times when someone else driving follows the map blindly and it's infuriating because you know there's a better way or through experience. And in the same way, do you think the next level of surgeons and entrepreneurs, will they become too heavily reliant on data that's fed to them? And how do you balance this blind trust versus years of experience?
I think
healthcare? Is it just driving example?
I think Basky mentioned very well that our generation will be gone and the next generation will totally rely on technology. That's how they were brought up with the smartphone they were at hand at a very young age. So I think it's going to be improving. So when you first use the Google Map, is sometimes not reliable, but nowadays we are almost like totally rely on those technology. So it only depends with the time development. I think the surgical accuracy will be improved by AI and also with the image guided of the procedure. So that will be a totally different world. So we are the older generation.
Right. And I guess, you know, my question around that, even being a younger generation, AI to me is only as good as the data behind it. And maybe this goes back to the question of electronic medical records. But beyond that, with yourselves looking at companies from, you know, to be newborns, cancer care, obviously robotics, that's not just simply electronic medical records. That's a wealth of information and data that needs to, I guess, really be unlocked or untapped for AI to be useful. Because I feel silo data is the most dangerous type of data where, yes, it may be great for one element, but you never know the knock-on effects or the other underlying issues it may have. So do you feel in terms of, I guess, moving on from AI or building on AI to the data side, is there data there today? I know there's a term that is kind of shared amongst industry, which is dark data. How do you move out from, I guess, a black box or dark data to well-lit room with a great filing compartment that you can get whatever information and run your analytics on it?
Yeah, I mean, and the other issue is garbage in, garbage out. So clearly you need curated data, and actually AI is the last 5 years has been hampered by sufficient amounts of curated data for training AI. And most of the papers that you read on AI are relatively small samples of data. I mean, when we need data, we need all the data. I mean, and we can't just have a fraction of the data. We need it all. And you know, most of the data in bytes is imaging data, and we need to really be able to process it. And all of my companies, you know, Leo Cancer Care is going to do a CT scan of a patient every time they're treated. And so we're going to know in exquisite detail what the dose distribution is in that patient's fraction. And they're treated multiple times. So we'll be able to know everything about how well we did. And so that data needs to be mined so that we can follow that patient in time and determine whether or not that care actually mattered or not. Or should we be treating something else? Should this node be treated or that node be treated? And there's a tremendous amount of work to be done once we start curating the data. And I really mean curation by physicians reviewing the data and then providing information so that you can train AI algorithms.
So,
yeah, I agree that we need a large data set, and we need the whole. And I think we also need the clinician to work with the engineer to annotate and correctly annotate the data or for the AI at the very development processing. So with the work on the cerebral with endovision, in fact, we found if we are just fixing the image, so if you just have an image of the video, we can make an accurate detection. But when it's become a video, a continuum of images, then the system has to learn a lot more. And not to mention also that during the endoscopic examination process, there may be some bubbling, there may be some food inside the stomach, so that would obscure the view. So how can AI actually learn this, background noises and avoid diagnosing a cancer from just a air bubble within the stomach? So that is also challenging. So we need a lot more data. I agree.
right. And Professor Basky, I mean, I know you mentioned that you already have electronic medical records. You're moving in that direction, getting digitization happening. What's your view on the holistic set of data and getting to that level and access to, I guess, a broader data set? Are there any issues? Are we on the right pathway there?
Not familiar with your term holistic data. You're talking massive data sets.
Yes, correct.
Yeah, I mean, you know, the problem we have with our current data sets is that we've traditionally collected this sort of a set number of variables for the last 30, 40 years. And as a very famous American said once, you know, there are the known knowns and the known unknowns and the unknown unknowns. So there's, let me give you an example in stillbirth. So a woman turns up with her baby dead today, and we have to deal with that. What we don't know is perhaps in the last week, she accessed information about reduced fetal movements 7 or 8 times. And we don't know that. Now, with our current system that we're implementing, it's possible, yes, we have our machine learning algorithms now. It's possible that as we collect the data, that the machine learning algorithm will include how often the woman accesses information on reduced fetal movements as a key factor in triggering her to come and seek medical attention. Yes, now we don't know that at the moment. It doesn't play any part in any of our prediction algorithms or treatment. Yes. So these kind of very nuanced information, for goodness sake, they use, you know, Facebook listens to me and sends me adverts all the time. Why in the world can't we use not just medical data, but social, cultural, behavioral data to help us better predict? So yes, so there are the known knowns, the medical data, the pixels on the CT, the pixels on the ultrasound, you know, the dosage of treatments we give, and the assessments of blood flow through the placenta. But there are also other factors that may work. So for in the UK, for example, the woman's postcode is an extremely powerful predictor of health outcomes. Yes, but how do we use it? We don't use it. But it should be. Yeah, it should play a part in how we do it. And it should play an evolving this particular postcode or zip code in 10 years' time, maybe an affluent area. Well, while right now it's a socially deprived, multicultural, urban inner city population with high morbidity. So yes, we must put in machine learning algorithms, but then we must recheck, revalidate, and develop as we go along. To sit down and say, I've developed the algorithm, go use it for the next 30 years is completely wrong. There must be a pipeline of ensuring that we get the data and continue to refine and recheck and revalidate and recalibrate all of our machine learning algorithms.
So, I mean, actually, that's a really powerful thing. And maybe, getting towards the end of our panel session, if I can ask my last 2 points, and the first one would be maybe building upon this known unknowns. We know we have to get AI and data sets from the existing medical records. But touching upon this whole topic of the unknown unknowns, I'm sure we'll have a second panel, hopefully sooner than later on this, but maybe very briefly, do you see this as possibly the next healthcare innovations, or do you see kind of a lot of industry and non-industry partnerships happening between big tech and health tech? Or do you need to have companies being created in between to bridge that gap? I mean, it's a really broad question. I don't think there's a clear answer, but for people watching today, and just to kind of inspire them on digging in those unknown unknowns and black holes to see where it leads to, is there any kind of thoughts from I guess, all of you on how to?
Yeah, I mean, the unknowns are because people haven't looked and they haven't explored. So, for example, Leo Cancer Care's premise is that we lie patients down on a couch. They walk in, they drive, they sit in the waiting room, and then we lie them down as if they're really sick, right? Yeah, they're sick. They've got cancer, right? But they should actually be upright. In fact, you can set them up just as well upright. The machines can be a lot cheaper upright. And so, but it's never been done. So people have to sort of say the following: why hasn't this been done? Is there not a better way to do something? The only way you really explore is you ask the question like, gee, what's on the other side of this ocean? Is there a continent over there? And medicine is the most conservative. I hear often in my life, well, we never do it that way. Medicine just doesn't do it that way. So there has to be people that are bold enough to say, well, why not? And what would happen if we did it a different way? And really, in radiation therapy, people, medical physicists, I was trained to be able to deliver very extremely uniform beams of radiation, right? So that the distribution was absolutely flat. And it turned out that that's the wrong way to treat. The best way to treat was to deliver intensity modulated beams, highly modulated beams, specific to the patient. And we spent 30 years with uniform beams until it was figured out that you shouldn't have non-uniform beams because you're going to have some exquisite dose distributions. So ask, is there not a better way?
Just adding to that, with this year, obviously the difficulties that we touched upon earlier in the panel. And yet the advancements happening in terms of adoption for digital data, telemedicine, telemonitoring, do you think that this year as helped people ask these questions, has helped innovation move forward? Or has it slowed it down because people have just become even more conservative to bet on the safest bet, not the most disruptive and innovative bet? Which way do you think this year has kind of swung healthcare?
Well, I mean, it absolutely has thrown a big wrench into it and created a lot of opportunities. For example, telemedicine I had an exam recently, a telemedicine so-called exam, but you know what? I had to go in to get my blood pressure done and my weight done and my height done. And, it would be relatively easy to have Internet of Things devices in your home that would do all of that and send it into the electronic medical records at low cost. Instead of building clinics. So there's an opportunity for entrepreneurs to have very simple devices, an Internet of Things that wires it to your electronic medical records.
And Professor Basky, do you think this year has thrown a wrench to make people more conservative, or really given the opportunity to say, look, we're going to go for it and ask these questions?
I think this year, I also agree it's enhancing the medtech development and also breaking a lot of walls between patients and clinician because of the social distancing policy, the development of telemedicine has been tremendous. And I think we also have to face the challenge in the past that we always say that the patient should be contact in a physical way to ensure their understanding and also their consent. But at this present moment, I think the technology is enhancing. So there's a lot of potential in this area. And secondly is that with the COVID situation, I think healthcare has been one of the top concern for human, all the community. So I think that also become a focus. So healthcare is not only about COVID. I think healthcare is about everything. So I trust there would be a even more focusing manner in this perspective. And thirdly, now we can also see the development and the cutting edge technology in the AI and robotics. So I think this area will be the next development in the next few years' time.
And Professor Basky, any thoughts on this?
Yeah, no, very, very briefly. When I was growing up, I was incorrectly taught that crisis, the Chinese word for crisis, meant both danger and opportunity. I've been subsequently told that that's wrong. But I think it's a good urban myth. Yes, there is danger. People sense the danger, and there are opportunities. And certainly for digital technology and AI, there are huge opportunities. And people have put health at the forefront. And social distancing has meant that they don't necessarily want to turn up at your front door in a hospital. So that's pushing AI and digital tech and ambulatory tech.
And I guess to round up the session for today morning then is for aspiring entrepreneurs and I guess even those within healthcare systems looking to innovate and push the boundaries, are there any advice, anything that you could impart on them to keep doing what they're doing?
I mean, ask skilled physicians what they'd like to see, but don't believe them. Ask them what they would dream of in the future, and then believe them, because I think that's in many ways the best advice. So physicians dream the big dreams, and don't solve their problems today. Solve the problems that they see themselves having in the future.
Yeah. So same here. I think the collaboration between a clinician and engineer is very important. So we have both be part of the innovation in the medical technology. So I usually just discuss about my dream of how we should deliver that kind of surgical treatment or the health care delivery, and then our engineer will find the solution, and we'll prove whether the solution is right or wrong by the clinical trial. So I think that's an important equilibrium.
Right, of course. Professor Basky, any last thoughts for the session?
No, I think Rob summed it up beautifully. Ask the clinicians what they dream of. Don't try and solve their problems for today.
Perfect. Well, thank you everyone for joining today's session, and of course, thank you to our panelists for that deep insight and some great advice for all of us looking forward for healthcare. And really, I think this year everyone has really come together from every sector of healthcare, and we really focus on the patient. And it's great to see these insights, which really, at the end of the day, are for and about the patient. So, thank you everyone, and we'll come back shortly with our next session in the next 15 minutes.